My name is Nisha Jhalani. I'm a cardiologist here at Columbia, I'm going to be doing the first presentation. But I just wanted to give you a little bit of background about how we came upon this topic and a little bit of background on CRF and our initiative. So the Cardiovascular Research Foundation is a nonprofit organization based out of Midtown, and its focus is on clinical research and physician education, so that we can help doctors help their patients. And a little over, or I should say, fall of last year, we started something called the Women's Heart Health Initiative, which was focused on education of the general public, healthy people or patients and families who can empower themselves through means of education. So we started a free educational seminar series, which we call Mini Med School. And the previous topics have been, general heart health, stress and heart disease. And this is the first time we've really looked at a patient-specific condition. So we're going to be talking about heart failure, and we've been working with the, world-renowned heart failure group here at Columbia. So hopefully everybody in the room knows, but heart disease is the #1 killer of both men and women in the United States. 1 in 3 Americans, based on the definition of heart diseases, including heart disease, stroke, and high blood pressure, 1 in 3 Americans has heart disease, is living with heart disease. The good news is that death rates are decreasing. So over the past 5 years, there's been a 25% decline in the death rates from heart disease, but heart failure rates are actually rising. And if you think about it, this makes perfect sense, right? The treatment for certain conditions in heart disease has gotten better, so that's why death rates are decreasing, but now people are living longer and sort of living with heart failure. And that's why there are currently about 6.5 million Americans who are living with heart failure. It's the leading cause of hospitalization in people over the age of 65. And this is kind of scary when I read this. Of all people 40 and above, 1 in 5 will develop heart failure at some point in their lifetime. And so looking at it another way, over the past 5 years, so from 2009 to 2014, the most recent update through the AHA showed that there were 800,000 new cases of heart failure over those 5 years. And that number is expected to rise, again, for the same reasons that we talked about, because better treatment options, people are just living longer in general. So that by the year 2030, there's going to be 8 million people living with heart failure. So what is heart failure? Let's back up a little bit. If you look at, I think a lot of names get thrown around, and a lot of heart failure is just a scary sounding phrase, right? There's no way to make it less scary. And so if you look at the definition in the 2013 guidelines, it's a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. So the way to think about that is the heart is a pump, right? And so heart failure is any issue with the pump, whether that's squeezing of the pump or relaxing of the pump. And so we talk about those terms. Systolic heart failure is what we usually refer to as heart failure, congestive heart failure, and that's a problem with the squeezing of the pump. But you can also have diastolic heart failure, where that's problems with relaxing, with the pump filling. You can also have problems with the left side of the pump or the right side of the pump, and that influences what side, what your symptoms are, how you present. The left side of the heart is the side that pumps blood to the rest of the body, and so that's usually what we think about when we think of heart failure. The right side is also, it's a smaller, and it pumps blood. It's a lower pressure system. It pumps blood to the lungs, but in certain conditions and in certain scenarios, it's actually right-sided failure. And we usually talk about, when we talk about heart failure, kind of the number that most patients who are living with heart failure know, by heart, is their ejection fraction. So ejection fraction is the fraction of blood that leaves the left ventricle during each squeeze. And normal is about 50 to 70%. So normal is not that the heart squeezes and all of the blood leaves, and it never fully empties. But 50 to 70% is considered normal. And this is usually measured through an echocardiogram. And that's just classically, anybody who lives with heart failure knows that they have either, echocardiograms every 6 months, every year, or whatever it is, based on your condition and the severity. So mildly reduced is in the 40 to 50% range. Moderately reduced is 35 to 40. The numbers, if you're 5% here or there, don't make all that much of a clinical difference. The only number that we use kind of as a cutoff for management is 35%. And so if it's less than 35%, you fall into this severely reduced category. And the way that that changes how your doctor will treat you is studies have shown that people who have a severely reduced ejection fraction for long periods of time despite medical therapy can be prone to certain arrhythmias, certain heart rhythms that could be dangerous or life-threatening. And so that's sort of the cutoff we use to put in a defibrillator. So for anybody who doesn't know what a defibrillator is, that's kind of this picture over here, where you see it kind of looks like a pacemaker. It goes over here. And best case scenario is that somebody gets a defibrillator and they never ever have to use it. So it's there just in case their heart tries to do something really terrible and tries to kill them. And in that case, it can try to pace the person out of it or try to shock them out of it. And so essentially it can save somebody's life. The other number, or the other entity that we talk about with having a severely reduced ejection fraction is cardiac resynchronization therapy, CRT. It's essentially like getting a pacemaker or a defibrillator in terms of the procedural aspect of it, but if somebody qualifies, if somebody's EKG shows that their right and left sides just don't really pump at the same time, and that could be contributing to why they feel so terrible, sometimes pacing the heart together so that the right and left side squeeze together can actually improve symptoms and actually improve survival as well. So those are the two things that kind of come at, that's the scenario in which the ejection fraction really makes a difference. Okay, so let's talk about what causes heart failure. This is a very, this slide will not do this question justice because there are so many different causes. And again, the terminology and the nomenclature gets thrown around so much because there's a lot of words that can mean the same thing. So if you break it down into two categories, you can have an ischemic cardiomyopathy. Again, cardiomyopathy is just another word for heart failure or not having enough systolic function, right? And so ischemic cardiomyopathy, it's usually somebody who's already had a heart attack. And so beyond the blockage, like seen in this picture, say you have a heart attack, this blood vessel is 100% blocked. For whatever amount of time, the heart beyond it, the muscle beyond it, is not getting enough blood flow, and so that becomes scar, and it can't pump with the rest of the muscle, right? And so for that reason, you can have, because that's now scar and not contributing to the overall squeeze, you can have an ischemic cardiomyopathy from that. And sometimes fortunately, if you have coronary artery disease, so blockages in a major vessel or enough blood vessels, where it hasn't yet caused a heart attack, it hasn't yet caused the heart function to deteriorate, it hasn't become scar yet. Sometimes if you find those blockages and fix them with either stents or bypass surgery, that can actually improve your heart squeeze, right? And so that's a reversible cause of a cardiomyopathy. So there's also then this group of everything else falls under non-ischemic cardiomyopathy, and that can include anything from, chronic high blood pressure, idiopathic, which just means we don't know what caused it. There could be a genetic component sometimes, myocarditis, so that's, it could be a viral syndrome, something else that sort of triggered this. Congenital heart diseases, things that people are born with. Again, hypertrophic cardiomyopathy, sort of genetic syndromes can fall under this. Valvular heart disease, another important thing to identify because that, again, if it's something that can be corrected through surgery or valve replacement, can actually reverse heart failure. Pregnancy, which we will talk about in the next presentation, can actually lead to a form of cardiomyopathy in and of itself. Thyroid disease, stress-induced, if somebody's in the hospital, very, very sick with, sepsis or something like that, that can be enough to strain the heart into having heart failure. Infiltrative diseases, so that includes any, the systemic diseases that can affect multiple different organs, including the heart. So as you can see, this is a very, very long list, and it's far from complete. But just to give you an example, these are sort of the main buckets that we group people into. And so what are the symptoms of heart failure? So it depends on what the cause is, right? And whether it affects the right side or the left side. But classically, if we talk in terms of generalities, the classic symptom is shortness of breath with exertion, right? And so if somebody could previously, run a marathon and climb 4 flights of stairs before they have to stop to rest, that's, and then now all of a sudden they can walk 5 blocks or, have to stop to take a breather after a flight of stairs, that could be a sign of a cardiomyopathy. It can also present with a chronic cough or wheezing. Rapid weight gain, so, changes in your fluctuations in weight could be a sign of fluid, of retaining fluid. And as can abdominal distension. So if your pants are all of a sudden tighter or you're loosening the belt or something like that, that can just be fluid that's accumulating inside the abdomen, and that can present with nausea or loss of appetite. Leg swelling, like seen in this picture over here, if you push your finger into your skin and it leaves an indent, that's water in there, right? And so that's another sign of fluid retention. The inability to lie flat. So if you look at this chest x-ray, even not knowing anything about reading chest x-rays, it's not quite normal, right? So the lungs this is a chest x-ray that's filled with fluid. And so if you imagine somebody who could previously lie flat using 1 or 2 pillows, and now it's not uncommon. Somebody will come in and say, well, for the past 2 months, I've been sleeping in a recliner because I'm just more comfortable. It's the only way I can fall asleep. That's a sign that there's fluid in their lungs and they've just sort of accommodated to that. And waking up in the middle of the night gasping for air, that goes along with it as well. And then other sort of non-specific things, fatigue, lightheadedness, palpitations can also be signs of heart failure. And then using those symptoms, we talk about heart failure functional class, and that kind of guides the intensity of treatment. So just to be brief on this, class 1 is no limitation whatsoever. Class 2 is slight limitation, meaning you can do ordinary activities, but at some point you have to stop and rest. It's not unlimited. Class 3 is marked limitation. Less than ordinary activity causes symptoms. That's the person who can't, walk from here to their kitchen without stopping. And then class 4 is symptoms at rest. And that guides, whether you start with medications, whether you start with, talking about, advanced therapies and stuff like that. So the treatment of heart failure. This is, I'm going to focus primarily on lifestyle modifications and medications, but first and foremost, if there's an underlying reversible cause, the treatment is to treat the underlying cause. So if there's blockages in the coronary arteries, that's why almost the first thing we do when somebody is diagnosed with heart failure is try to rule out coronary artery disease, because that would be a reversible, treatable cause. Same thing with valve replacements. Nowadays, with newer and newer valve technologies, we're able to do a lot more valve replacements in the cath lab as opposed to with open surgery. So that's become a big area of interest. And then if we look at lifestyle modifications in heart failure, if there's one slide that you really pay attention to for anybody who's living with heart failure or taking care of somebody who's living with heart failure, this is probably the most important one in my talk. And it's because if you're already on appropriate medications, following these steps can really be the difference between somebody who's hospitalized every month or somebody who can stay out of the hospital for years at a time, because heart failure is very much a disease or a condition that if the person is empowered and understands how to take care of themselves and adjust their medications and what they can eat and drink, it very much can keep you out of the hospital and keep you healthy. That and a good relationship with your doctor. And so the first and foremost, just like we talked about with the symptoms, it's all about fluid retention, right? So you don't want to wait until you're sleeping in a recliner or you have, pitting edema in your ankles or anything like that, because that means that it's gotten too far. So somebody with heart failure should actually check their weight every single day, roughly the same time. So we say after you wake up, after you urinate, before you eat or drink anything is ideal. And if your weight goes up by more than 2 pounds in a day or 5 pounds in a week, you should call your doctor, because that may mean that you have to adjust your medication regimen, your diuretic dose. Check out doing it. Okay. I'm going to be brief. And then we also, you also need to limit your fluid intake because it's all a balance of ins and outs, right? So the more you drink, if you're urinating and responding to diuretics, the more you drink, it's just going to undo that. So you want to limit that to less than 1.5 liters per day, and that includes all forms of liquid, not just water. You want to limit your sodium, right? And so it's not just the table salt that you add on things, but it's processed foods, things like cold cuts and cured meats and breads and rolls and pizza, soup, cheeses. Anything that comes in a can is just intrinsically high in sodium. You just want to be very cognizant of it. So the same number as before, 1.5 grams per day. Avoid smoking, alcohol, caffeine, and high stress. Hopefully nobody smokes, but this is, again, another very important point. Caffeine in moderation, we get that question a lot. Usually 1 cup of coffee in the morning to get you going is not going to make or break things, but again, discuss it with your doctor. Participating in regular physical activity or cardiac rehab is another thing that you sort of train your heart to live with with whatever your ejection fraction is. So the more active you are, the more able you are to do things. And then we sort of don't talk about this a lot, but getting your annual flu shot, getting your pneumonia vaccines, somebody who gets the flu, somebody with heart failure who gets the flu, they're going to be a lot sicker than somebody else, or me that gets although right now I probably shouldn't get the flu. All right, so common medications for heart failure. Again, this is, I'll be very brief on this. Anything that ends in OLOL, the beta blockers, so carvedilol, metoprolol, are sort of part of the cornerstone of heart failure therapy, as are the ACE inhibitors and ARBs. If it ends in pril, it's an ACE inhibitor. If it ends in sartan, it's usually an ARB. And those both have survival benefit in people who are on heart failure. The newest medication that's been shown to have a survival benefit even over the ACE inhibitors is the angiotensin receptor neprilysin inhibitors. Just came out within the past year. Is not in guidelines yet, I don't think, but will soon be, and is kind of something that the heart failure physicians prescribe much more often than general cardiologists, but I think the use will be growing shortly. So it's actually a combination pill that uses valsartan, which is an ARB, along with a neprilysin inhibitor, which is a new class of medications. And so that's something that is used in heart failure by the heart failure physicians. Hydralazine isosorbide dinitrate, the brand name is Bidil, that showed a survival benefit, particularly in African Americans with systolic heart failure. And then also aldosterone antagonists, diuretics, digoxin, oxygen, those are all also used. And diuretics have not been shown to improve survival, but reduce hospitalization are kind of, again, another cornerstone of heart failure therapy. The second half of our talk is going to focus on advanced heart failure therapy, so I'm not going to touch on this at all, and I kind of want to wrap up there because I think I want to leave time for all of our other amazing speakers. So thank you for that, and hopefully that was not too rushed of an introduction. So without further ado, I want to introduce Dr. Jennifer Haythe. She is the co-director of the Center for Women's Cardiovascular Health here at Columbia. She's also one of the advanced heart failure attendings with the cardiology division here, and has a specialty in women's heart health as well as pregnancy and a whole bunch of other things, and is a fantastic speaker.
I'm glad to see so many women in the audience. I'm trying to frighten some of you today. That was part of my goal. And then hopefully you'll go home and scare all the other women in your life. So I'm going to touch on some of the things that Dr. Jhalani said a little bit, but I just want everybody here to know that heart disease is the leading cause of death for women in the United States. And you'd be surprised how few women know that and how few doctors know that. Heart disease kills 1 in 4 women. Heart disease kills more women than all cancers combined, and that's by a huge, huge margin. Heart disease is here at 305,000. This is from 2008. Stroke is down here at 80,000. Breast cancer is down here at 40,000. And yet, somehow, nobody knows this, and women don't know this, and women don't pay attention to this, and the media doesn't care. And I suspect that it's because heart disease somehow isn't very sexy. It's not fun to talk about. People feel stigmatized. They feel like it's their fault, that all people with heart disease are fat and lazy and eat cheeseburgers and don't exercise and brought it upon themselves and smoke. And that's actually not true. Sometimes it's true, but it's not always true. And I want people to know that they shouldn't feel ashamed, and we need to get the word out to protect women. And really, you know, what's critical about it is that I like to say to patients, you know, breast cancer, you can't really do anything about whether you're going to get breast cancer. I mean, you can do genetic screening and you can get your mammogram, but heart disease, almost every single risk factor is modifiable. So rather than looking at it as a negative, try to turn some of those risk factors or some of those diagnoses into a positive and something that you can actually do something about. So only 54% of women polled identify heart disease as their number one killer. 64% of women who die suddenly of a heart attack had no prior symptoms. Okay, so that should make everybody like sit up and take notice, okay? In the first year after a heart attack, women are 28% more likely to die than men. Women are less likely to be prescribed ACE inhibitors, beta blockers, statins, and less likely to receive a defibrillator after a heart disease diagnosis. So if the medical community isn't paying attention to you, the best thing that you can do is educate yourselves and tell your doctor, wait a minute, why haven't I been prescribed this medication? Why aren't I getting a defibrillator? Why aren't I getting prescribed cardiac rehab? And, you know, why this is happening is not totally clear. Is it because women minimize their symptoms? Is it because they say they don't need it? Is it because they don't understand that they need it? Or is there just a bias in the medical community where women aren't being treated equally to men? So even though this is a heart failure talk, you know, Dr. Jhalani said that coronary artery disease or ischemic cardiomyopathy or heart failure from heart attacks is actually the number one cause of heart failure for women and men in this country. And so I think we need to just talk about the heart attack symptoms that are different between men and women, because this is the most likely path that women will take to developing heart failure. And while we know that in men, as depicted often in the media, while women are never depicted in movies or films as having a heart attack, it's crushing chest pain, nausea, sudden onset, they're playing tennis, they're having sex, it's funny, it's in a movie. Women aren't ever featured that way, they're never depicted that way. And interestingly, when they actually looked at it, chest pain is still the number one symptom, but women also can have things like a profound sense of fatigue or some trouble breathing, flu-like symptoms, indigestion, or symptoms that last for a number of days before seeking medical attention. Here's another image of women heart attack warning signs. So cold sweat, abdominal pain, very common for women to feel, symptoms of indigestion, paleness or clammy skin, inability to sleep. Another one I get from a lot of women is just felt like something wasn't right. Just felt like I didn't feel myself for the last few weeks. I'm not sure what's wrong. 90% of women have one risk factor, at least one. And that's a lot of people, 90%. So whether it's high blood pressure, high cholesterol, diabetes, smoking, poor diet, physical inactivity, obesity, and for women, we can add on preeclampsia. You know, there's other risk factors that affect women differently from men. So like we just saw a slide about causes of heart failure. Heart failure in women have almost exactly the same causes as men, except you can add in peripartum cardiomyopathy, which is heart failure that develops during pregnancy or in the first 5 months after pregnancy, as well as stress cardiomyopathy, which can happen in men, but is much more common in women. Chemotherapy-induced cardiomyopathy also tends to be more common in women because it usually comes from the chemotherapies used to treat breast cancer. So like Dr. Jhalani pointed out, this is a typical systolic heart failure heart, as opposed to a normal heart where you see that the heart is normal size and nice and small. This is a big dilated heart that doesn't pump normally. And the symptoms that you see are shortness of breath, swelling, lack of energy, trouble sleeping at night, confusion or impaired memory, urination problems, cough with sputum, or swollen or tender abdomen with loss of appetite. And this is true for men and women. So just to talk about peripartum heart failure, I don't want to scare lots of women because it's not that common, but it can happen. So it develops in the last month or within the 5 months of delivery. It's diagnosed as having an ejection fraction of less than 45% without any other identifiable cause of heart failure. And so what's important is that, like other causes of heart failure in these women who are pregnant, the ventricle gets enlarged and the heart's pumping ability goes down. So what are the risk factors? So I always like to say that advanced maternal age, so that's the old elderly age of 35 years old, is considered advanced maternal age. So that's basically everybody in New York City and probably most of the rest of the country at this point. Obesity, smoking, alcoholism, multiple pregnancies, African American descent, malnourishment. So what do we do to treat these patients? They're pregnant. Some of them are still pregnant. If it's after pregnancy, it's slightly easier, but we usually use the traditional heart failure medications: ACE inhibitor, beta blocker, digoxin, diuretics. If you're pregnant, you can't be on an ACE inhibitor or an Entresto, but you can be on a beta blocker, digoxin, and diuretics. Actually, after delivery, you can be on an ACE inhibitor at low doses. So women who have this should, depending on how severe it is, be treated more aggressively. So what do we know about what happens to these women in time? So usually the traditional thinking was that a certain percentage will get better, a certain percentage will stay about the same, and a certain percentage will get worse. And we know a little bit more information now that women who have a better ejection fraction and less dilated hearts, when they show up at the doctor, are more likely to recover their heart function within 6 months. And women who recover to normal are more likely to tolerate subsequent pregnancy without a death or serious consequence. But that doesn't mean that their heart will be normal. It could still deteriorate further. So this is a hard topic to talk about because I think it's very confusing for patients, because it's very confusing for the medical doctors in the community. So the patients are obviously going to have a hard time understanding it. So there's something called diastolic heart failure, or heart failure preserved ejection fraction. And we just spent all this time explaining to you that heart failure means that your ejection fraction is reduced, right? So what is this preserved ejection fraction? So what we've realized is that people develop a dysfunction in their heart, but it's not categorized by their ejection fraction. Your heart function actually may appear normal by ejection fraction, but your heart is actually impaired. And this happens because of years of high blood pressure, diabetes, smoking, poor diet, obesity, sleep apnea, and the heart becomes stiff and thickened. And as you can see in this picture, this is in systolic heart failure, you have this dilated ventricle, but in diastolic heart failure, your heart is very thick and the chamber actually becomes small. So less blood is pumped here, and here there's actually less blood in the chamber for each episode of the pumping. So the pumping may be normal, but there isn't enough blood in the chamber to get a good cardiac output. And so people come in and they have symptoms of shortness of breath, their legs are fluid overloaded, they don't feel well, and their echo says that their heart function is normal. So how do I have heart failure? Well, you have diastolic heart failure. Your heart can't relax well. And it's not easy to reverse this because it took years for your heart to get this way. So you can't just suddenly change it. So what do we do to try to help symptoms? Well, we give diuretics to help unload some of the fluid. We try to control blood pressure because often many of these people have poor blood pressure control. We do weight loss strategies. We treat sleep apnea that's been undiagnosed. And sometimes we have to convert people into normal rhythms instead of atrial fibrillation or other arrhythmias that make it harder for the heart to pump well. So Dr. Jhalani asked me to touch briefly on pulmonary hypertension, another complicated medical problem that can be very hard for patients to understand and also for doctors. So this is a little bit confusing. I tried to find a simple image, but basically what I like to tell patients is we check your blood pressure in your arm and it's supposed to be 120/80. You check your pressure in your lungs, it's supposed to be 24/12. And the reason your lung pressures are so low is that the lungs are just supposed to be this nice passive pool where the blood travels through, picks up oxygen, lets go of carbon dioxide, and then comes back to the left side of the heart to be shot out to the rest of the body. In pulmonary hypertension, for a variety of different reasons, the pressure in the lungs is much higher than it's supposed to be. So instead of being 24/12, it might be 40/20, 60/30, 100/40. And as the pressure gets higher, the right side of the heart has harder time pumping against that high pressure because it's really not designed to do that. And so even heart failure patients might hear the word pulmonary hypertension, because heart failure causes pulmonary hypertension because there's too much fluid in your lungs. And so sometimes before you're evaluated for an LVAD or a transplant, your doctors will make you get a catheterization to review the numbers of your lungs and see what the pressures look like and see if you're a candidate for those things. So what are the symptoms of pulmonary hypertension? Very similar to heart failure: tiredness, blue tint or lips or skin, shortness of breath, swelling of the abdomen or legs and ankles. And it's divided into 5 different categories. There's pulmonary hypertension. There's left-sided heart disease, which is heart failure causing high pressures. There's lung diseases like COPD and emphysema. There's CTEPH, which is multiple blood clots. And then there's an other category for things like sarcoid or unclear mechanism. The treatment of pulmonary hypertension really depends on the cause. So sometimes we'll treat with medications. You may have heard of drugs like Viagra or sildenafil. Those are drugs we use to treat Cialis, to try to dilate the blood vessels. Sometimes people need valve surgery. Sometimes they just need oxygen. We offer a surgery here to remove blood clots if that's the problem. And ultimately, sometimes people need lung transplant. So in the last few minutes, I'm just going to try to inspire people a little bit like Dr. Jhalani did, to be in charge of yourselves, because really the best way to survive a long time is to look out for yourself, and that's pretty much true for anybody in the whole planet. So ask yourself, can I breathe as well as I usually can? Am I getting out of breath when I do things that I used to do without a problem? Am I coughing? Am I using more pillows? Is my weight changing? How much has it gone up or down? Sometimes you can lose weight, and that's not normal either, right? So heart failure patients often gain weight because they're swollen, but losing weight is also a sign of really advanced disease, because when you start losing your appetite and losing weight, that's a sign that your heart failure has progressed. New or worsening swelling, changes in your ability to do everyday things. Medication. I can't tell you how many people show up without any clue what medication they're taking. You should not put a pill in your mouth unless you know what it is and what it does and what it might do to you. And you should write it on a piece of paper, and you should bring it into your doctor and say, this is my list of medicines. And you should lay them out in a pill box, because I don't care how smart you are or how whatever, it's very easy to forget. I take antibiotic for 1 week for a cough, and I can't even remember if I took it the day before. I can't imagine having a list like this, okay? It's not an easy task, so treat it like it's not easy and pay attention. Vital signs. Again, if you have heart failure, you should monitor this every day. You should wake up, go to the bathroom, get on the scale, and write down your weight. If your weight changes by 5 pounds or 3 pounds, you call your doctor. I can't even explain to you. I have people who say, I gained like 40 pounds in the last, month. Where were you? Where have you been? My office is open. Call the number. Like, that is not normal. Check your blood pressure, check your pulse. Diet. So you got to have a low-salt diet. It sucks. I know. We all want to pour salt all over everything, but you have to get used to eating without salt or some kind of alternative. Herbs, garlic, be smelly and terrible to those around you, but do something that makes your diet better. You have to exercise. Having heart failure is not excused to not exercise. If you feel nervous, get your doctor to prescribe you cardiac PT and have someone monitor you. You can walk, you can bicycle, you can do light weights, you can do yoga. You can do a lot of things that stretch your body and make you feel good. You have to talk to your doctor about how high your heart rate's allowed to get and what's appropriate, but there's no reason not to do that. Meditation, so increasing evidence of the mind-body connection. We didn't really talk about it, but stress cardiomyopathy, which affects more women than men, is actually an incredibly stressful life event causing an acute heart failure syndrome that often goes away. But it looks like you're having a heart attack and you're not, and your heart function drops to nothing, and it's real. So what can we do to reverse that? Get control of stress. We live in an incredibly stressful world. I called the summer camp my kids are going to, and I was like, how do you protect against people coming with guns to kill all my kids? And he was like, you're not the first person to ask me that. Like, the world is terrifying. We're all stressed. You're like scared to go into Times Square, you're scared to go to a movie theater. You have to find a way to get control, because it really has deleterious effects on your body. Meditate, download an app to your phone, relax, close your eyes for 20 minutes, try to find some sense of calm in the day. Depression, it literally affects everybody. of all races, ethnicities, ages, women or men. I put women here because I was asked to talk about women, but there's no reason to live feeling depressed. We have really good medication to treat depression. It makes heart failure worse. It makes your medical care worse. It makes your life expectancy lower. So there's no shame in taking Lexapro or Zoloft or Prozac, the same way that there's no shame in taking, metformin for diabetes, okay? It's the same problem. It is a chemical imbalance that needs to be treated. That's my 2 cents. Family history, know your family history. Talk to your grandparents, talk to your parents, talk to your cousins and aunts. Find out if anybody had heart disease. This is the one risk factor you can't alter. If a mother or father had a heart attack generally before the age of 60, you should be concerned, even if you run a marathon every year. Go to the doctor and get a stress test. And finally, I want to encourage women to talk to each other and learn about their heart disease symptoms, share them with each other. Don't feel ashamed. Don't feel like you can't talk about it. The more that we talk about it and the more that we know, the less guilty or embarrassed people will feel. That's it.
So I'm going to kick it up a notch and talk about advanced heart failure. So I'll touch upon 3 points. I really want you to come out of this session understanding what advanced heart failure is, identify your needs or what the symptoms are of advanced heart failure, and explore the treatment options. I'm going to start with talking about understanding what advanced heart failure is. Heart failure really is a pandemic. It affects 23 million patients worldwide. There are 5 million patients in the U.S. There are 885,000 new patients who develop heart failure every year. There's a million of heart failure hospitalization every year, and 50,000 patients die every year. That translates into 156 people dying of heart failure every single day. It's very costly to healthcare. What do you think is the healthcare cost a year, or at least it was in 2012? $32 billion. What do you think it's projected to be in 2030? $70 billion, right? That's a lot, and it's almost not sustainable. So the way to try and prevent this dramatic growth is to develop research. And what Dr. Jhalani showed and Dr. Haythe showed that heart failure is a lethal diagnosis, and there are a lot of patients. There's 5 million heart failure patients and roughly 390,000 lung cancer patients, but heart failure is grossly underfunded. The NIH gives around 30 million for heart failure, but 135 million to lung cancer. So that's why it's really important to raise awareness that heart failure affects a lot of people and it's lethal. Heart failure is a progressive disease, and ACC and AHA divides it into 4 stages. Stage A is when you don't have evidence of heart failure on your echocardiogram, but you have risk factors such as hypertension, diabetes, and obesity. Stage B is when you start to have evidence of structural disease, but you have no symptoms. Stage C is when you have symptoms and structural disease, and stage D is severe symptoms. When we as medical doctors talk to each other about a heart failure patients, we use New York Heart Association classification, and there are 4 classes. Class 1 is somebody who has absolutely no symptoms but may already have a disease. That's a runner. Class 2 is when you start to slow down and begin to feel shortness of breath. That's a walker. And class 3, when you're really only comfortable at rest. That's a guy sitting in the park. And class 4 patient is when you're just uncomfortable. These stages are reversible with medications that Dr. Jhalani showed to you earlier. And we've gotten really good with medications in treatment of heart failure. When you had a disease in the 80s and only had an ACE inhibitor and an ARB, we could reduce mortality only by 10 to 15%. But now with the combination of the newest medicine that came out, Entresto and the beta blocker and MRA, we can reduce heart failure mortality by 63%. So what does that mean? If we have 100 patients with heart failure, nowadays 63 of them will be alive. And if you had heart failure in the 80s, only 10 to 20 of them would have been alive. So that's impressive. This is somebody who I saw last year. This is an echocardiogram, and this shows a quivering heart, right? There's really no squeeze. On the right side, there's a left ventricle, which is supposed to squeeze blood into the main artery called the aorta. And the ejection fraction here is 20%, so this is severe heart failure. This is the same patient just less than a year later, and you could see how robust the squeeze is. And he didn't have heart transplant, he didn't have a pump. All we did is we put him on great medications. So nowadays, the disease can be reversible. Class 4 is when you're very uncomfortable, and that happens occasionally because disease is progressive and medications no longer help, is advanced heart failure. There are 250,000 patients who have advanced heart failure, and a heart transplant and a mechanical pump really the treatment options for these patients that can make a difference. Unfortunately, over the last year, we've only done roughly 2,800 heart transplantations and 3,000 heart pumps. And the number of heart transplant hasn't really changed dramatically over the years, but the number of heart pumps, rate is on the rise. Now I want you to focus on identifying the needs. What does that mean, I have advanced heart failure? Advanced heart failure patient is someone who constantly have to come into the hospital for tune-ups. I'm short of breath. I'm tired all the time. My blood pressure is too low. I can't walk. My ICD fired. My legs are always swollen. This is advanced heart failure. This is the point when you should be referred to a tertiary care center that can do a heart transplant or offer you a mechanical pump. This is what heart failure looks like. You can't bathe. You have this nagging cough that just wouldn't go away. You feel bloated and your legs are swollen. So once we understand what advanced heart failure is, what are the treatment options? And the treatment options are sort of threefold: either a heart transplant, an LVAD, or palliation. And I'm going to start with palliation. And palliation is for patients who are not candidates for either a heart transplantation or a mechanical pump. And unfortunately, the outcome of these patients is not great. By 2 years, people who are on palliation, less than 10% of these people will be alive. Transplant is the gold standard treatment, but as I said before, over multiple decades, the number of heart transplantation hasn't really changed. Worldwide, we've done about 5,000 heart transplantation, and I showed you there's 250,000 patients who have advanced heart failure and probably would qualify for a heart transplant. The survival after a heart transplant is excellent, with a 1-year survival of 88%. 88% of the patients will be alive at 1 year, and with a median survival of 11 years, that at least 50% of patients will be alive by 1 year. And if you make it through the first year post-heart transplant, which is the most rigorous one, then the median survival becomes 13 years. Heart transplant is a disease. You have to take care of it just like you would of any other diseases. It requires a lifelong immunosuppression, it requires frequent biopsies, and the sequelae of a lifelong immunosuppression, such as cancer and infection because the immune system is suppressed, are real. Now on to the LVAD. If you Google what an LVAD is, this is what the Google says. A left ventricular assist device, an LVAD or a VAD, is a mechanical pump. It's placed inside a person's chest where it helps a heart pump oxygen-rich blood throughout the body. It's not an artificial heart because it does not replace your own heart, but it works in conjunction with the heart and helps it pump. It's an open heart surgery. And really, an LVAD patient is not so much unlike an Ironman. It has a metal pump that's inside the chest. There are 2 batteries that power the pump, and there's a controller, which is like a little computer that's outside that controls the pump. The evolution of the heart pump technology really had been tremendous over the last decade, and we went from this huge, bulky, what's called a HeartMate 1 was the first generation pump that was implanted in the belly into the latest generation pumps that can fit into your palm and very small. So this is a HeartMate 1, and we call it a pulsatile pump because it just like your heart, it squeezes and relaxes and squeezes and relaxes. And it was great at the time, but it's not very durable, and it required a major surgery. You could see this on the right, that this is somebody's belly trying to accommodate the pump. So luckily for us, this is no longer produced. And we're now upgraded to a HeartMate 2. This is the most commonly implanted pump. And you could see the inflow cannula goes into the left ventricle. This is an axial flow device, like in propeller, and it propels blood through the outflow graft into the main artery called the aorta. And it helps the heart pump. The heart squeezes and the pump keeps moving. Heartwear is another pump that's approved by the FDA, and it's more like a washing machine. It's called a centrifugal flow pump, and it's partially magnetically levitated. The pump is suspended by partial magnetic fields, and it's sort of similar. It has an inflow cannula, the actual pump that sits inside the chest, and has an outflow graft that brings the blood into the aorta. The LVAD can be a bridge to transplant, i.e. the patient comes in and very sick and can't wait for a heart transplant for months or for a year. So we give them a heart pump and support them until they're able to get a heart transplant. Or if they don't qualify for a heart transplant, they get an LVAD as a destination therapy. The outcomes of these mechanical pumps are excellent. The bridge to transplant patients do very well with an excellent 1-year survival. Either it's a HeartMate 2 or a Heartwear device of over 85%. Destination therapy, similar. By 2 years, and these people tend to be sicker than the bridge to transplant patients, over 60% of these patients are alive, and it certainly beats optimal medical therapy, where less than 10% of patients are alive, but not quite as good as a heart transplantation, although this may not be an entirely a fair comparison, as destination therapy patients are usually a bit older. LVAD has complications, and they're real, and it's bleeding and clotting and stroke and infection and right-sided heart failure and a pump failure. And at least some improvement in technology has done away with a pump clot. This is the newest pump that is currently being tested and Columbia is one of the sites, and we've enrolled the most amount of patients. And this was published in New England Journal of Medicine, which is one of the most prestigious medical journal in our community. And Dr. Nalka, who is our surgeon, and Dr. Colomba, who is our medical director of the program, are on the paper. And this pump is superior to the most commonly implanted pump, HeartMate 2, mainly because it has no blood clots. So the technology keeps improving and improving and improving. And most importantly, if you were to ask a patient who is on the mechanical pump a year out and said, if now you know everything, with the knowledge that you know now, and we had asked you a year before, would you have done this over again? And over 60% of patients say absolutely yes. So be your advocate, understand your disease, understand your needs, and explore your treatment options. Be your Iron Man or woman. And in the audience, we have 3 Iron men and women, and we have Joe. Can you stand up, Joe? Thank you. And Harold. And Angela, and they're heart failure survivors. Thank you.
So as you've heard, there's been really remarkable progress in drug therapies for heart failure over the last 30, 40 years. You've heard about, you have diuretics. These are drugs that help you keep fluid out of your body, which is normally what happens. One of the key symptoms in heart failure is this fluid accumulation, so diuretics help us get rid of the fluid. We have these other drugs called ACE inhibitors or angiotensin receptor blockers, and these help the arteries to relax and make it easier for the blood to be ejected from the heart. And we have beta blockers, which also help the heart strength improve a bit. And so these are really the mainstays that you've heard about. More recently, you've also heard about this new drug, Entresto, which is a combination of an ARB and another drug that releases or that helps to enhance a natural, one of the body's natural proteins that helps also the body get rid of fluid and also help the blood vessels to relax. That's the Entresto combination. And there are other new advances that are not as major as the Entresto, but the point is that there is really significant advances that we've experienced and that have been made recently, and there's a number of drugs that are also under investigation now, and I'm sure that some of these will be available in the decades to come, years and decades to come. However, while we have many benefits of drugs, they help you live longer, they help you feel better, but they're not always back to where you might consider to be normal. So drugs definitely help us, but they don't bring us back to normal. Also, patients experience side effects. Some patients don't always take their medications as prescribed by their doctors, partly sometimes because of the side effects, partly because they forget, and sometimes they just don't want to be bothered. And even when drugs are used appropriately, they sometimes lose their effectiveness over time. That means your symptoms will return or continue to worsen. And this is where devices aim to pick up. So devices aim to pick up largely where drugs leave off. And devices try to help you live even longer. They try to make you feel even better. And they also help make the most out of the drugs that you're prescribed. Once devices are put in, some devices work without any need to do anything on a daily basis. So this reduces the need for compliance, what we call compliance. So you put it in and you don't have to, it does its job automatically. Other devices need daily care, or you have to do something to make the device effective. All devices, at a minimum, require periodic monitoring to make sure that they're working properly. And as you've just heard in the last talk, devices, especially the ones that are invasive, are associated with risks, but these risks are generally outweighed by the benefits that they provide to patients. And this is really the purpose of the clinical trials that we perform before devices are made available to the public. And that's the process by which they get FDA approval, where we show that the benefits outweigh the risks. So devices can be scary to some patients. Some of them are big, some of them are smaller, as we'll see. And it really takes a lot of, I think, interactions with the physician and support with the family to understand if a device is right for you. And the one thing I'll mention with regard to the topic of the symposium today is women and heart failure, is that women are underrepresented in clinical trials of devices and also in medications in heart failure. And we don't really know all the reasons why that is, but this has really caused concern that we don't know if devices really, are they really as effective in women as they are in men? And we need to have physicians and also the community understand that we need to encourage women to participate in the clinical trials that we're running to advance the field and also to improve the health of these patients. So devices already have an important place in the armamentarium in the fight against heart failure, as we've already heard. We've heard about the internal cardiac defibrillator, ICD. This treats dangerous heart rhythms, so this helps to save lives. It doesn't necessarily make you feel better, but it's very important in that it will save your life in the event of a significant, what we call an arrhythmia, which is when the heart either beats too fast or actually stops beating. These are devices that can help can jumpstart the heart in these conditions and be very life-saving. We've also heard about the CRT, the cardiac resynchronization therapy, and these devices, CRT devices, are usually combined with a defibrillator. And these devices help increase the strength of the heart. So these help you feel better, but they're not indicated for all patients with heart failure. In fact, it's only about 1/3 of patients with heart failure who qualify for the CRT device. So that leaves 2/3 of all patients with heart failure not able to receive the benefits that we know exist with CRT. And that's kind of a preview to the fact that there is an unmet need, and these unmet needs are really what is driving innovation that I'm going to talk about towards the end. There's another device that has just recently been approved and not widely used at this point, but these are implanted pressure sensors. The physician, your doctor, can put a small pressure sensor inside the artery in your lung, and this helps to detect when fluid is accumulating in your vascular system abnormally. Once this information gets transmitted to the cloud, then that information from the cloud goes to your physician or to the nurses that are taking care of you, and they can get warning signs well in advance of the point when the fluid is accumulated to a dangerous state. This allows the physicians to intervene early and prevent these hospitalizations. This is put in with an invasive procedure called a right heart cath, and those of you who have undergone right heart cath, you know what this is all about. A small plastic tube is put into the vein in your leg or in your shoulder and advanced into the artery in your lung. So this is the artery in your lung. And this device here, it's a little bit larger than a dime, can be placed and left in place in the artery. And this device then will transmit to a receiver that you put on your bed, and you can measure the fluid content in the body. And this again will help physicians know when fluid is accumulating and allow for intervention. That's another kind of device that this allows the physicians to optimize the medications that you're taking, and also can serve as a reminder. Well, give you a call, your pressure's rising. Did you take your medicines? Maybe you need a little bit more. Have you been, eating too much salt, drinking too much water? So that's really an advantage of those kinds of systems. Ventricular assist devices, you've heard a lot about them. You've heard about the HVAD with the HeartWare and the HeartMate 2 and the HeartMate 3 from Abbott. And you've seen this animation before, which just shows that this device doesn't replace the heart. It takes the blood, it withdraws the blood from the ventricle, it unloads the ventricle mechanically and bypasses the left ventricle and pumps the blood into the aorta. And this has really shown remarkable effects in taking patients with severe heart failure and helping them live a near normal life. Oops. So those are the devices that we have available to us. And what about innovations? Heart failure is a place where there's a lot of room for innovation because the devices that we have are not perfect and are not applicable to all patients. So there's a recognition in the field that we need improved device-based therapies that are less invasive, that have less side effects, that are more effective and also more reliable. And I'm just going to give a few examples. I talked about this pressure sensor that can be put in invasively and transmit the information. Well, there's a clinical trial going on now with a device that's non-invasive that does the same kind of thing. It doesn't exactly measure pressure, but it uses radar to transmit across the lung fields and measures the amount of fluid that's in the lung. So this is really doing conceptually the same kind of thing, but it's non-invasive, and people, like with the pressure sensor, you make one measurement a day, the information is sent to the cloud, and then the information is brought down to the clinician, and they can then act accordingly. So this is one example of innovation. This is now in clinical trial throughout the United States. Less invasive ventricular assist devices. This has been the holy grail of MCS for decades. And we had, for example, in trial, one such device which, instead of being implanted by a surgery with the device sitting inside of the chest, was put in with a catheter-based system. And instead of the device being inside of the chest, the device sits under the shoulder, under the skin, just like a pacemaker. Now, this device is still in development. It's had some experience with clinical trials in Europe, but is now, because of problems that were identified, is being redesigned, and hopefully will come back into clinical trials soon. But this would be a major advance where you could put a ventricular assist device in a patient without having to take them to the operating room and put them under general anesthesia and all the other complications associated with the surgery. And finally, I just want to mention that there are a lot of new concepts. So I've shown you where we're taking invasive devices and trying to make them less invasive and non-invasive, but there are a lot of new concepts that are being explored. One is the relationship between the brain and the autonomic nervous system and the heart and the vascular system through the use of electrical signals. The brain, of course, and the nerves that attach to the heart and the vessels are all controlled by electrical signals passing between them. And there are multiple devices that are being put in, and with electrodes being placed in different places in the vascular system and in the heart, that are intended not to increase the strength of the heartbeat, but that are sending signals to the heart and to the vessels to try to tell the vessels to relax, tell the heart to work better, to get back to a more normal function, and to help the brain kind of deal with all the information that's coming from the different places in a different way than it is doing in the heart failure state. So this is like the pacemakers, like the CRT, like the ICDs. They're electrical devices, but they hook up to the body in different ways, and they do different things. We have devices that are trying to block the parts of the heart that are not working. This is called the parachute device. This looks like an inverted parachute. And this is intended to be placed in patients who've had a heart attack where a portion of the heart is not pumping properly. And if this device works, it's still investigational, it's put in and it walls off that part of the ventricle so that when the normal part of the heart squeezes, it doesn't lose energy by expanding that part of the heart that's not working. We have, and I'm sure that everyone has heard about stem cells. So one of the ultimate treatments for heart failure would be to replace the failed muscle or the muscle that's been lost. Very early in the game, it's been researched for now almost 20 years, but it's still extremely early. But there's still progress being made in the area of stem cell therapy. And similarly, you've all probably heard about gene therapy, which is making advances in other areas, is also very slowly but making progress in the field of heart failure. Another form of interfering and modifying the neural system in heart failure is called renal denervation. This is the kidney over here, and the kidney is, there are many nerves that go to and from the kidney to the brain, kidney to the heart, etc. And these nerves send signals that make the condition worse in heart failure. And we have systems that try to actually destroy these nerves in an attempt to prevent these abnormal signals from going back to the brain, which make the heart failure worse. And finally, there's a lot of progress being made in percutaneous, I mean, using catheter-based systems to treat abnormal valve function. So most patients with heart failure, systolic heart failure, the heart gets bigger, and because of that, the valves that separate the chambers don't work properly. And there are many efforts to try to either replace those valves or to modify them to make them work in a better condition. So this is just a glimpse of the future. There's a lot of innovation that is underway. So I think that the future is bright for future patients with heart failure. And we rely on physicians and patients alike to participate in the clinical trials that lead to these advances. So I think I'll stop there, and thank you very much for your attention.
So maybe the question that comes up is, let's say you have heart failure and the cause has been established. What are the key things that patients really need to look out for in terms of what they do with their daily life? Maybe, Audrey, you want to? We're all very polite here, so.
It's important to be aware of your symptoms by measuring your weight daily, the same time when you first wake up, after you urinate, and keep a daily log, and monitor your legs if you have any swelling or bloating, and just be aware of your own changes in how you feel, if you're more short of breath. Anything else?
Just to build on what Maureen is saying, everything she said, plus the slide that Dr. Haythe put up earlier that had the little picture showing the symptoms of like the swollen feet and legs and the shortness of breath or the cough. So all those things, and keep in close contact with your healthcare team, your doctor, your nurses, the folks that you're seeing in the clinic or in the office. Very important that you stay in close contact with them. And if something's changing or doesn't seem right, call early. Don't wait.
I think the biggest thing here is change, and you heard that from several people. Most people know what their baseline is, but if there is a difference in that, and some of that may be fatigue, some of that may be other things, but if you notice a difference in what's actually going on, that's something that ought to prompt you to at least make a phone call or get advanced help. The problem nowadays with a lot of physicians' offices is it's very hard to get a hold of the physician, or it's hard when you call to get that type of help. And as Jen and others have said, you have to be persistent and you be in charge of yourself. If things don't feel right, that's really important to then go and try to figure out why that might be. Any other thoughts? And maybe in terms of the physical activity, you know, this is something that people always worry. What can I do? What can't I do? Should I push it? What are your thoughts on that?
I think that you know, it really depends on the level of heart disease and your class of heart disease, whether it's class 1, 2, 3, 4. Obviously 4, you're probably not doing much, but I think it's very important to stay in close touch with your team. I think it's very important to exercise. I think that exercise can certainly improve your quality of life and enable you to do a lot more than you otherwise would have been able to do. And here we see patients with every form of heart disease, whether it's MI, all the way up to LVAD. I'm sure my guys have worked with a lot of you guys. And I think it's safe to say that physical activity will certainly improve how you function on a day-to-day basis.
Yeah, I think the other thing about physical activity that's really important is that if you're used to a certain regimen, then it's easy to tell when it's changing and when things are getting worse or when they're better. If all you do is sit on the couch all the time, those are the patients that as physicians we worry a lot about, because you have no idea if things are getting worse or bad because they're not really doing very much. And so if you're active to whatever degree you can be, that allows you to establish a nice baseline, and then you can determine if you're varying from that baseline or not. Great question on nutrition. Maybe, and you could talk a ton about it, but maybe some basic tips. It's certainly very important, but what sort of tips might you offer?
First and foremost, low sodium diet, and I think most of our presenters stress that. Great question, by the way, from the audience. Certainly less than 2 grams of sodium. Learn how to read nutrition labels. Seek out help from a dietitian or a nutritionist. Your healthcare providers can help you get hooked up with folks with that expertise to help you learn more about healthy diet.
And also, your fluid intake has to be limited to about 1.5 liters to 2 liters. So you should keep track of how much you're drinking and how much fluid you're taking in. And especially around now, like the fruit is a big thing. People don't realize there's a lot of free water in the fruit, so you don't want to eat too much of that because that adds also to the fluid intake.
And I think that's why the weight is so important as well, because as the weather gets warmer, you'd have to increase your fluid intake to some extent, because otherwise you'll get dehydrated. But on the other hand, if you increase it way too much, then you're going to get overloaded. And so weighing yourself, same time, every day, same sort of situation can really help in that regard.
Best thing to do is to check with your healthcare provider, call your doctor's office, speak with your healthcare team. If you're being told by your cardiologist, your primary care doctor, that you have heart failure, then you're going to ask very specifically for a guideline related to the amount of fluid you should be intaking every day. And the guideline that we heard earlier from Dr. Jhalani was less than 1.5 liters daily. And that's a very important guideline. That's all your fluids included for the entire day. Anything you may be drinking, not just water, it adds up quickly. And those regular size Poland Spring bottles, it's a total of 3 of those in a 24-hour period.
Yeah, I think
I try to emphasize with my patients in like balance, make sure that what you're taking in is coming out. And a lot of my patients use rescue doses of diuretics because it depends how advanced you are in heart failure. If you keep in mind that whatever you're taking in should come out, you actually keep a balance. That's why when you weigh yourself, you know that you are doing well or you need something extra.
And it will vary a little bit based upon the type of heart failure you might have, systolic versus diastolic, how severe it is as well. But that's why these things need to be tailored. But regulation of your fluid intake as well as your nutritional status are going to be really key ways that you can modify the disease. And that's important for patients because a lot of times they feel that they've been given this disease and there's nothing that they can do about it. And you shouldn't feel helpless in that regard. There are specific things that can be done, and lifestyle modification is really important cornerstone of that.
calling your healthcare provider would be the best route to do for guidance. You don't want to take, sometimes you don't want to take it right away because it may be too close to the next time you're going to take a medicine, which will lower your blood pressure or heart rate, even lower than what it normally is going to do. So it is best to kind of call your healthcare provider. Also keeping a pill box like we had seen in some of the lectures earlier to keep you organized so you know what you're doing, and carrying a list is really important. So and reminders on your cell phone work. There's a bunch of different easy ways to remember.
It's also important to understand the effects that the medications have. So our presenters earlier were talking about, I believe it was Dr. Haythe specifically said, don't put any pill in your mouth without understanding exactly what it's for and what it does for you. So a number of the heart medications actually can lower your blood pressure and heart rate, as Maureen was discussing. It's important to understand what exactly they do, because your healthcare provider may ask you to actually space out the timing of those medications on purpose so that you don't have untoward effects of taking them all at once.
I mean, I can take a stab at it. I think that some of it has to do with the fact that, there have been a lot of studies conducted in male populations. I think some of it has to do with the fact, maybe I'm prejudiced. I always think women are stronger. And so they focus on the weak men and how we need to help the men and everything like that. But it's a conundrum. It's basically one of those things where the women are sort of, again, I'm totally editorializing here, are supposed to hold everything up until they can't, and then have to deal with it. And that's not the right way to approach this. I mean, basically, there needs to be a focus on early detection, early screening, and awareness, so as to keep those women strong. Double the age of the men, because we die off early.
I think many reasons. I think women are lasting longer. We're developing symptoms later. Our weekend with heart attacks later. Our coronary disease is happening later on in life. Most of us don't get intervention because it's not a reason. No amenable for intervention. A lot of women have multivessel disease that you cannot really fix. So we're developing heart failure symptoms later. Postmenopausal women are having more heart failure with diastolic heart failure, and they last longer. Women are smaller, take care of themselves. They have less activity, so they have less symptoms. And sometimes women, when they come to us, they're far advanced in the disease, even though their symptoms cannot be as advanced. So it's true. And women are having run clinical trials. It's very hard to enroll women in clinical trials as a research subject. So we are working as a community on getting to that, but it's true.
So maybe a question, we heard a little bit about depression. How do you manage that? And maybe we'll expand this not just in heart failure, but also the LVAD population, patients with advanced therapies. When the disease does happen, you have to confront that. So what resources might there be for people?
Especially with our LVAD population, I think it's so important that you don't forget that this is, you've come to a point where this is sometimes your last resort is turning to a mechanical pump, and it's life-changing. So you've been living with heart failure for a while and kind of just tucked it behind you and dealt with it, and then all of a sudden you're faced with this pump where your life changes, in an instant, because now you're not only just living with heart failure, but you're living with a mechanical device that teaches you how to live a different kind of life. So definitely what Dr. Haythe had mentioned, depression isn't something to be ashamed about. I think that was such an important message that she brought up, that it is sometimes a chemical imbalance, whether it's life, things that happened emotionally, physically, mentally, but that taking a pill that can help you feel better emotionally and mentally will help. And I think what's important that we've incorporated with our LVAD and heart failure patients is that, we've really incorporated palliative care into our program. And I think ever since we started doing that to our heart failure and end-stage heart failure patients, they have been more open and willing to discuss life goals, interests, concerns, and even end-of-life goals. So that has helped manage their emotions or depressions and concerns about heart failure and end-stage heart failure.
I think a lot of people are just afraid to talk about it, or they spend the office visit talking about the medications and what can be done. And if you haven't talked to that about somebody, it can be very, very difficult to then just broach the subject. But it's very common in patients after heart attacks. It's common after patients with heart failure. The other aspect too, with heart failure, when your heart's not pumping as well, there's not as much blood flow to the brain. And so there can be mood disturbances and other things that happen. Plus, people are very fatigued all the time. And you know how, if I don't eat all day and then I go home and, read the news, I'm more cranky than I normally am. So it's just one of those things that can happen. So I think it's really important to recognize that. And if your physicians or people who are taking care of you are not sympathetic to that, then that's the onus is on them to be able to try to address that part of things as well.
If I may add to that, so it's normal to hear the diagnosis heart failure and be frightened. That's a very normal reaction, and you don't have to just live with that on your own. Talk to your family, talk to your friends, and sometimes the best folks you can talk to are objective people who don't necessarily know a lot about you personally, or psychotherapists exist, social workers can help counsel you, and it's important to seek out these healthcare providers and put them on your team to help you advocate for yourself and deal with lots of big things like this.
So let's talk about the fear for a second. So if I have heart failure, can I pick up my grandkids? What things can't I do? And also it's important for family members, because a lot of times people have a heart attack, they have heart failure, and then we hear, 6 weeks later from the patient that, they're not being allowed to do anything because the family members are so afraid to allow them to do things. So physical activity, sexual activity, what can or can't be done?
Well, if you were old enough to have grandkids, I would tell you that yes, you could pick them up, and you have to sort of grade your activity depending on what's going on with your heart and how you're feeling. If you're in a weakened state, maybe sit and hold them, maybe not walk with them. Anytime you do any activity where you're carrying extra weight with heart failure, heart disease, you're going to put more load on your body, more load on your heart. So maybe stand still and hold them, sit and hold them. Try not to walk up a flight of stairs holding your grandkids, or up an incline or a hill. So yes, you can hold your grandkids. As far as being afraid, I think that goes along with the depression. I think that goes a lot along with how patients feel and the perception of, oh my God, I had this heart attack, I have heart disease. Something really bad is going to happen to me if I start exercising. Well, probably something really bad is going to happen to you if you don't start exercising, because you're now increasing your risk again of having a secondary event. So I think it's important to get with your healthcare team, perhaps go to a cardiac rehab program where they can monitor you carefully, check your blood pressure, heart rhythm, heart rate, sort of guide you through the initial stages of exercise so that you can see that, hey, I am safe doing this. Barring that, patients that we see here in the hospital, we give them home programs to sort of guide them along. And one of the biggest things is always, can I walk up a flight of stairs? Well, we usually walk patients up a flight of stairs before they go home to make sure they're okay doing that. We sort of guide them along and give them a home program. I think it's a very important part of the post hospital experience, or even living with heart disease. Right.
I think, Dr. Haythe, the only reason why we wouldn't tell patients to not lift their grandchildren would be if they were to have open heart surgery, so such as after an LVAD procedure where they do an open chest, a mid-sternal incision. That's when we advise our patients to wait at least 12 weeks for the sternum to heal before lifting and carrying heavy, not just children, heavy materials, so that's something that we would advise. And obviously, if you after 12 weeks and you want to carry your children and you have your grandchildren, you have the LVAD, we always say, please be careful, because children can step on the drive line, step on the the controllers and the batteries, which can then pull on these devices. So
I think that it's tough. Some of this is very individualized, and it's hard to make generalizations. But in general, when patients have heart failure, The good thing is that there are medications, as Milana showed, that can help not only stabilize things, but in some cases improve things as well. And depending on the type of heart failure that you have, there are some types that stabilize, there's some types that improve, and there's some types that unfortunately get worse. It's only something that time can tell, and the things that are within your control are the lifestyle modification things that we talked about, the medications, and for certain other patients, they may need more advanced therapies as well. But what's different now than maybe 20 years ago or 30 years ago is in those times, literally you gave somebody a diagnosis and it was like a death sentence. And I don't think that's the case anymore. And maybe others can comment on this, but there are a host of options, and we don't often offer all of those options to everybody because they may not need them. But those options are there if things were to get worse, and we certainly hope for many patients that things can actually get better. So it's kind of a generic answer to what you're saying, but I think it illustrates somewhat of the depth of how far we've come with regards to heart failure management. It's not solved. There's a long way to go, and Dan certainly showed some innovations as well. But there are more and more options now for people, and so my hope would be that all those things you want to do would come true.
I could.
Yeah, go ahead.
I could say I could. I could tell you a little bit about the exercise portion for you. You're young, you're active, you have a daughter, you want to do stuff. I would say exercise if your ejection fraction is stable and your team, says that you're stable. Exercise to the point of your own symptoms. You know what they are: shortness of breath, dizziness, palpitations, pressure, pain. If you experience any of that, obviously back off. But over time, you can slowly increase the amount you're doing, because if you're not symptomatic as you're slowly over days and weeks increasing a little bit, it's not going to change what's structurally wrong with your heart, but what goes on in the periphery of your body, your legs, your muscles, all the metabolic systems that power your muscles, those become more efficient. So you'll be able to do more with what you have here. So it is very important to continue to exercise and to exercise to your capacity.
Yeah, I know. I think actually the points that you're making about being the difficulty in explaining things in this situation are universal points, and it doesn't matter what stage of disease you're at or whatever disease it is, unless you're the expert in the disease. It's all new, it's all foreign, and everybody's best guess is Google now. That's the only way people can sort these things out, unfortunately. And so I think that what happens a lot of times, and that's really the importance of establishing a relationship with a single person. And it may not have to be a doctor. It could be a nurse practitioner. It could be a social worker. It could be anybody, but who can explain things to you in a way that you can understand them. That helps. Because I got to tell you, even if somebody were to tell you, there's some patients who want to know exactly what their numbers are. There are other patients who just want to know the general picture. There's some patients who want to have the general picture explained in a way that they may be able to understand at that particular time. And for many physicians meeting patients for the first time, you can't tell which of those the patient wants. And so it's not the patient's fault, it's not the physician's fault. I think the key is the communication over time is what enables you to build the rapport. And Milana's your doctor, right? So I'm sure that that's what I'm saying. I'm sure that she has a way of being able to explain things to you in a way that you can understand it in your construct, and that's the key thing with most of these states. So it's interesting in terms of the pulse rate. It varies based upon the individual patient. It varies based upon whether they're exercising or not. And a low pulse in marathon runners, they have some of the lowest pulses you'll see. But as you get older, if you have a low pulse, and that's typically 60s and below, that can signify some fraying of the wires or the conduction system of the heart. But it depends on the patient. It depends on whether you're having dizziness or other symptoms. And the reality is that if there's a concern about that, that's something that you should seek attention for, because it may be totally fine, but it may not be as well. In the case of heart failure patients, frequently the pulse is high to compensate because the heart is weak. So each beat can't pump as effectively, so the heart has to beat more frequently to pump the same amount of blood. So that is the case in heart failure, but that doesn't mean anything unless you individualize it to your individual scenario.
That's a very good question. Yeah, it's a very good question. So actually, there's no set limit or time that after 5 years we need to go in and replace it. There would only be certain occasions where it would be required to be replaced. Otherwise, as long as it's functioning properly, you're not having any symptoms or heart failure symptoms because it's not working appropriately, then that's a concern that it would need to be exchanged. So currently our longest patient within LVAD is going on his 11th year with the device.
One quick question about the batteries. Can you go to sleep on battery, or what do you do with battery packs and that sort of thing?
I mean, I get.
You-
And
yeah,
what's the and what's I hope the answer was do not sleep on batteries, right? Okay, good, because that would be the right answer, or else Google's absolutely wrong. But yes, we absolutely recommend to not sleep on batteries because obviously we say the batteries last 10 to 12, sometimes even 16 hours, but it's not always a guarantee. The last thing you want to do is not ever wake up from your sleep. So you sleep on the grounded outlet, and if you were to lose power, it would alarm loud enough to wake you to let you know there's no power, and therefore you would switch to batteries.
I think you are used to having, I mean, at least you're a transplant person, but you're used to have a glass of wine and you're okay with that, you enjoy it, by all means, I don't think we recommend that people start drinking if they have never drink for the healthy benefit. There's a lot of controversy regarding that, but it's, as you know, it's 2 glasses per man and 1 per woman. People with heart failure will be very, very careful. If you want to enjoy a glass of wine because you have a special occasion, by all means, but I will stick to that.
Yeah, I mean, you just got to watch the fluid intake, and you have to watch for excess of it. Those are the 2 key things.
Well, I just have to say though, unfortunately for our LVAD patients,
That's the difference.
because they are taking Coumadin or warfarin, it has such a strong interaction with alcoholic beverages that we do not recommend any wine, alcohol, any beers because of such potential to increase your Coumadin or your INR.